It's my great pleasure to, together with my co-chair, Daniela Romaldi, to open this session on what is new in PCOS. And it has indeed been a good start to the morning with the beautiful weather. For those of you not familiar in London, the weather's always like this here. And secondly, the morning started very well with all the good news from Mexico City. Without any further ado, I'll hand over to Daniela to introduce the first lecture.
Good morning again, everybody. It's my greatest pleasure to introduce the first speaker, Dr. Zachary Nash, who will address one of the hottest topics nowadays in PCOS management, which is glucagon-like peptide receptor agonists. So he will talk about the cardiometabolic effects. Please, the podium is yours.
Thank you. Thank you to the ESHRE reviewers for selecting our study, glucagon-like peptide 1 receptor agonists, GLP-1s, for the improvement of cardiometabolic outcomes in women with polycystic ovary syndrome. A systematic review and network meta-analysis for an oral presentation this morning. I have no conflicts of interest to declare. The following statements are taken from the 2023 International Evidence-Based Guideline for the Assessment and Management of PMOS. Women with PMOS should be considered at increased risk of cardiovascular disease, and regardless of age and BMI, women with PMOS are also at increased risk of impaired fasting glucose, impaired glucose tolerance, and type 2 diabetes. Metformin alone should be considered in adults with PMOS and a BMI equal or greater than 25, for anthropomorphic and metabolic outcomes, including insulin resistance, glucose, and lipid profiles. GLP-1s were initially established as a treatment for type 2 diabetes, followed by recognition of the benefit of weight loss and improvement in cardiometabolic outcomes. A range of compounds are available, and the recommendation from the same 2023 guideline is that anti-obesity medications, including GLP-1s, could be considered in addition to an active lifestyle in management of higher weight in adults with PMOS as per general population guidelines. The recent James Lind Alliance Priority Setting Partnership for PCOS identified as a further research question, what are the effects of anti-obesity drugs on women and people living with PCOS as a top 10 research priority. So we began by undertaking a systematic review. A literature search was conducted with the assistance of an information specialist, and we identified 21 RCTs, 14 of which met the inclusion criteria, which were RCTs of human participants with PMOS receiving GLP-1 interventions compared to either an active agent or placebo published in the English language. A network meta-analysis was then undertaken, allowing both direct and indirect evidence to be synthesized within a connected evidence network. Between study heterogeneity was modeled and assessment of risk of bias was undertaken. For each outcome, a visual network plot, pairwise comparisons, forest plots of direct evidence, and probabilistic ranking of treatments, including sucra, were reported. Statistical tests were reported with two-sided with a normal significance level of less than 0.05. Pre-specified outcomes were broadly consistent with the core outcome set for PCOS, which included waist circumference, insulin resistance, and lipid profile. Outcomes for this study can be divided into body composition, represented by BMI, fat mass, and waist circumference, and metabolic outcomes, including total cholesterol, components, LDL, HDL, triglycerides, and insulin resistance assessed by HOMA-IR. The first outcome of interest is BMI, and this exemplar network plot of BMI shows a fully connected network, allowing estimation of all pairwise comparisons through both direct and indirect evidence. The size of the nose corresponds to the number of participants randomized to each intervention, and interventions with direct head-to-head comparisons are connected by lines, with the line thickness proportional to the number of trials evaluating each comparison. So for this outcome, 14 RCTs contributed to the network, comprising 7 treatment nodes and 693 participants. Key pairwise comparisons which met significance. So placebo was consistently associated with higher BMI compared with GLP-based 1 treatments, as you would expect. Liraglutide, liraglutide plus metformin, and semaglutide all showed significant BMI reductions versus placebo. Interestingly, liraglutide combined with metformin was associated with a 1.02 unit greater BMI reduction compared with metformin alone, suggesting a benefit to combination therapies. However, other comparisons between different GLP-1s and between combination and monotherapy regimes were generally imprecise, with confidence intervals crossing null. Probabilistic ranking of the most effective treatments for BMI reduction in women with PMOS showed higher probabilities for weight loss with GLP-1-based treatments alone or in combination with metformin than metformin alone or placebo. Similar to BMI, when looking at waist circumference, liraglutide, and metformin and semaglutide all reduced waist circumference and tended to favor greater waist circumference reduction compared with several comparators, although some estimates were imprecise with very wide confidence intervals. In contrast, exenatide combined with metformin and placebo were generally associated with increase in waist circumference across comparisons, which is difficult to explain. Overall, the pattern of effect suggests that liraglutide and semaglutide regimes may be more favorable for waist circumference reduction than exenatide-based regimes or placebo, though uncertainty remains due to those imprecision and sparse direct evidence. When ranking GLPs, semaglutide and liraglutide again ranked higher than metformin or placebo. FATMAS had a sparser network with 6 RCTs comprising 5 treatment nodes and 359 participants. Significant evidence of benefit was observed for metformin, which was associated with a 0.77 unit reduction in fat mass versus placebo. Liraglutide demonstrated a larger effect with a 1.3 unit reduction, whilst liraglutide plus metformin was associated with a 1.12 unit reduction in fat mass relative to placebo. And again, with probabilistic ranking, liraglutide was first and liraglutide and metformin second. Key findings which reached significance for total cholesterol. So liraglutide combined with metformin consistently demonstrated greater total cholesterol reduction than key comparators. Compared with metformin alone, liraglutide plus metformin significantly reduced total cholesterol, providing evidence for improved lipid outcomes with combination therapy. Liraglutide and metformin also significantly reduced total cholesterol compared with liraglutide monotherapy, indicating additional benefit from combination therapy. Liraglutide and metformin also showed greater cholesterol reduction compared to placebo, as you would expect. Again, when ranked, GLPs alone and in combination with metformin ranked higher than metformin alone or placebo, with the exception of exenatide monotherapy. Considering LDL cholesterol, so-called bad cholesterol, liraglutide in combination with metformin was consistently associated with greater LDL reduction than key comparators. Compared with metformin alone, liraglutide and metformin showed evidence of reduced LDL by 0.38 millimoles per liter, indicating improvement again with combined therapy. Significant difference was observed when liraglutide and metformin was compared with liraglutide monotherapy, with a 0.45 millimole liter greater LDL reduction, demonstrating evidence of added benefit of GLP use beyond GLP use alone. Again, when ranked, GLPs alone in combination with metformin ranked highest, with the exception of exenatide monotherapy. Considering other lipid outcomes for HDL cholesterol, no GLP-based therapy showed a clear advantage over metformin, and for triglycerides, active treatment generally favored triglyceride reduction compared with placebo, with the strongest and only statistically supported evidence for exenatide combined with metformin. For insulin resistance measured by HOMA-IR, most comparisons favored active treatment over placebo, with larger negative mean differences generally observed for GLP-1 therapies, particularly liraglutide and liraglutide plus metformin. And this suggested directional improvement in insulin resistance, however, none reached statistical significance. Across outcomes, comparison-adjusted funnel plots showed no clear evidence of bias from the fact that many small studies were included or publication bias, with most of the outcomes pooled around 0. So limitations and reasons for caution. So the outcomes reported were in keeping with the relevant core outcome set. However, all were surrogate outcomes for the development of cardiovascular disease or diabetes, as you'd expect from these sort of studies. This review was designed to evaluate GLP versus standard care and placebo. Trials that did not include GLP-1 intervention weren't systematically captured. And this meant that estimates for metformin versus placebo were informed by the evidence within the network rather than the full historical literature. But this doesn't change the conclusions drawn about GLP compared with metformin and placebo. Assessments using the Cochrane risk of bias tool assess most studies having some concern, mostly because of concerns around blinding. And for several outcomes, the number of contributing trials and participants was limited. Many treatment contrasts were informed by single studies, and missing data reduced precision. So finally, the summary is that GLP-1-based therapies, particularly liraglutide and semaglutide, both as monotherapy and in combination with metformin, were consistently associated with more favorable effects on body composition outcomes, including BMI, waist circumference, and fat mass, compared with metformin alone or placebo. These effects were most pronounced for BMI and waist circumference, where several comparisons demonstrated statistically and clinically meaningful reductions, particularly for liraglutide plus metformin and semaglutide. Metabolic outcomes demonstrated greater heterogeneity and uncertainty. For lipid outcomes, combination therapy with liraglutide and metformin showed the most consistent evidence of LDL and total cholesterol reduction. Given the limitations and the reasons for caution, there should be caution about enthusiasm for the conclusions in relation to clinical practice. But this does raise the question that future studies should evaluate GLP-1s and consideration of GLP-1s and metformin combination therapy in appropriately selected populations of women with PCOS. Thank you.
Thank you, Dr. Nash, for this comprehensive review of the literature on this topic. Is there any question from the audience? Professor Belen over there.
I can hear you, but it's...
You can hear me?
Yeah, there you are.
That is working now. Adam Balen from Leeds, UK. Thank you very much for presenting the data. Of course, we're in the midst of an explosion of the use of these medications, and my question and comment really is obviously we have to be cautious about longevity of effect, rebound when these drugs are discontinued, and of course the safety, particularly for those who are wishing to conceive. And so it's very interesting looking at these comparisons, but from a pragmatic and a therapeutic point of view, I think we need to think a little bit more carefully about the longer management of our patients.
Absolutely.
And if you have any comment about that, the concerns about rebound when these drugs are discontinued as well.
I think that's certainly a concern in other populations. These studies were largely a primary outcome around 12 weeks or a little bit longer. So absolutely, I think as part of a well-constructed study, those sort of questions are needed.
Rick Grow, Penn State. So I question, is it worthwhile to do a network meta-analysis when you only have 693 patients, 14 studies? You know, really, what is the power when you're looking at so many different outcomes? Do you ever just say, the heck with it, not enough, move on to the next topic? And this is not just you, there's some of these that are really underpowered to draw any definitive conclusions.
Absolutely, there are limitations both to the literature and your analysis. I think the reason that we pursued this is because it's such an interesting topic clinically, and this is what's available. So we ran with what was available, but we're very cautious about the interpretation and the conclusions can pull for more evidence rather than any change in clinical practice.
Thank you.
Thank you very much. I think it's time to move to the next presentation. Thank you very much for your presentation. Thanks for the comments.
Okay, the next presentation comes from Massachusetts. It's by Stilian Ragios, and it's called Metabolomic Profiling of PCOS Insights from the UK Biobank.
Thank you. Hello everyone. I am Elias. There you go. Yeah, I'm still someone of the fellows in Boston. And my presentation is metabolomic filing of polycystic ovarian syndrome, PCOS, inside the India Biobank. We have no triggers. And let me just start by saying that that may be a little bit outdated. We submitted before running PCOS to PMOS, polyendocrine metabolic ovarian syndrome, and what changes that afterwards. Now I think we're familiar with the fact that this is running happens, but it reflected the fact that PMOS is a syndrome that encompasses diverse and endocrine, metabolic, reproductive, dermatologic, psychological features, and not just an isolated ovarian disorder. It's very common. It affects over 170 million women around the globe. And we now have many studies and analysis and specifically genomic analysis that show polygenic origins across endocrine, metabolic, and reproductive pathways for PMOS. Hyperandrogenism plays a defining role both as an endocrine feature but as a diagnostic feature as well. Many patients present with acne, hirsutism, alopecia, or other metabolic derangements. And we also know that obesity is increased in patients with PMOS, seen in 40 to 60% of them, and it has been implicated as causal on Mendelian randomization studies, and it is also known to exacerbate the symptom severity. We care a lot about PMOS because on top of the reproductive features, ovulation, infertility, it's also associated with impaired glucose tolerance, type 2 diabetes, cardiovascular disease, stroke, and hypertension. So the purpose of this study was to delineate the metabolomic profile in patients with PMOS and try to capture metabolic and reproductive phenotypes and pathways. So this is a cross-sectional analysis of the UK Biobank. The UK Biobank includes over 500,000 participants from 40 to 60 years old, recruited between 2006 and 2010. And they have a lot of information about their patients. We included only the patients that had available nuclear magnetic resonance-based metabolomic profiling, and they had information on 251 metabolites spanning multiple metabolic domains, multiple metabolic pathways such as sugars, lipids, amino acids, and others. We had two groups. Our first group, the study group, included PMOS patients, slightly over 1,000 of them. And then our control group, we formed it by nearest neighbor matching through 1 to 5 ratio by age and BMI, and we had around 5,500 participants in this group. We performed sub-analysis within different BMI strata with a cutoff of 25, and within different free androgen index strata using 5% as a cutoff, in order to better evaluate for effect modification and also try to identify phenotype-specific metabolomic signatures. We performed linear regression models, adjusting for potential confounders, and we used a p-value of less than 0.5 for statistical significance. This figure shows that our two groups were well matched for age and BMI. Mean age was 48.3 for both groups, and mean BMI was 30 for both groups. The study participants were predominantly white, 90.6% for the PMOS group and 89.4% for the controls. And also the majority of the study participants were premenopausal, 57.5% for the PMOS group and 56% for the controls. This is mostly a descriptive figure showing the relationship between the metabolomic traits under evaluation with PMOS across all analyses. The first column shows the results, the adjusted results for our total population. And it shows that 134 out of the 251 metabolites were associated with PMOS, indicating a PMOS-independent metabolomic signature. The next two columns show our results within the different BMI strata. As we see, there is marked heterogeneity within the different BMI groups. In the lean PMOS patients, normal BMI group patients, only 11 out of the 251 metabolites were associated with PMOS. However, in the elevated BMI group, 108 of them were associated with PMOS. And then the last two columns show the results within the different free androgen index strata, and they display kind of a more selective pattern. 117 metabolites were associated with PMOS in the low free androgen index group, and 61 of them were associated with PMOS in the elevated free androgen index group. And then this figure shows the proportion of altered traits by metabolite family and how they were associated with PMOS after adjustments. Again, minimal disruptions in the normal BMI group. And then across all other analyses, we primarily saw associations with PMOS within the lipid metabolism metabolites, triglycerides family, and fatty acid composition metabolites. This is a busy slide with a lot of words in it. I just want to leave it on for a few seconds so that you can scroll through it and get an idea of some of the metabolites that were under evaluation. It's not even half of them, it's only a few of them. And then this figure shows in a little bit more detail the lipoprotein subclass disruption seen in PMOS patients. Again, minimal disruptions in the lean PMOS patients, but also for the most part in the elevated free androgen index sub-analysis, except for VLDL. And then across all other analyses, we did see consistent associations with PMOS, primarily in the VLDL group, but also in the LDL and the HDL families. Moving on towards our discussion, we did see that PMOS is associated with a distinct metabolomic signature beyond age and BMI. And the dominant signals that we identified involve the lipoprotein classes, triglyceride-related measures, and fatty acid composition. We did see that probably the metabolomic disruption may not be universal across all PMOS phenotypes. Lean PMOS exhibited a substantially attenuated metabolomic profile. And then lastly, that BMI appears to be a stronger determinant of large-scale metabolomic remodeling compared to hyperandrogenism. Of course, there are several limitations with a study like this. Primarily, we did not have enough information on the classification that was used for PMOS definition. And of course, we also have the inherent limitations of cross-sectional study design. Also, of course, the fact that our findings were primarily of descriptive nature limits the interpretation. But I do think that studies like that can create the basis and the framework for future work. I think interesting next steps would be longitudinal metabolomic analysis following patients for a more prolonged amount of time and see changes within the same patient. Integration of metabolomics with proteomics and genetics. Try and predict cardiometabolic outcomes using metabolomic signatures. And then the identification of metabolomic biomarkers for phenotype-specific risk assessment. That's what I had. Thank you for your attention.
Thank you very much. Questions from the audience?
Hi, Niels. Yeah. Niels Lambalk from Amsterdam. Just for the maths, you had 1,000 PMOS patients. I still prefer to call it PCOS anyway, but it comes from 500,000 persons, of whom half were women, 250,000. So you only had 0.5% of this population. Or am I looking at it in the wrong way?
You do look at it the absolute correct way. The only thing is that initially the biobank, the UK biobank, did not have metabolomic information on all of the study participants, only some of them. I think now they have incorporated that into the total cohort, but now they have a positive availability to download the charts of these patients. But I think in the future we'll have information for all of them, hopefully.
Thank you. Lady down here.
Thank you. Very nice presentation. Terhi Piltonen from Finland. Just asking you whether you were able to look into the lean phenotype without hyperandrogenism. Are you able to say that they do not present any metabolomic changes? Were you doing any sub-analysis on this group?
Say that again. Which
normal androgenic lean.
Do a combination essentially of the over two groups. So I think that's an excellent suggestion for building up the paper.
Yeah, okay, very good.
Hello, Ioannis Messinis from Greece. Just data are interesting, the way that you presented metabolic findings in a disorder that is considered metabolic. However, polycystic ovary syndrome are mainly the patients that you used for this study, because the PMOS is a very new definition. So why didn't you use PCOS then? Because there's still debate whether in fact this is the correct definition or not, because there are a lot of endocrine disturbances and of course in the ovary. So, I mean, this probably, your patients were not PCOS, were not PMOS, but they were PCOS.
Correct. I mean, we used PCOS to select our patient's population. I used PMOS for the presentation for the sake of the new term, but PCOS was the term that was used to, select the patient's profiles. Probably they will be the same down the line, but.
Any further questions?
I have a question.
Just to enter into the argument about PCOS and PMOS, it's a bit like X and Facebook. Every time X is written, then you have to have Facebook in brackets so that people know exactly what you're talking about. And I'm afraid I'm still in brackets, but I'm sure this discussion will go on for a long while.
I am happy to remind all of you about a session on the name change, which will take place on Wednesday at, it seems to me, at 8:30. And we will talk about all the process which brought us to change the PCOS name into PMOS. But where is the speaker? Go back, come back. Excuse me, I have a question for you. He's going out. We have still 2 minutes for you for question and answers. Don't go away, don't leave me, please. Because I have a philosophical question. After the Rotterdam criteria were released more than 20 years ago, you were a young child, I think, at that time. As healthcare professionals, we try to phenotype women. At that time, we divided all the PCOS population in 4 subtypes, 4 phenotypes. Now we are going to extremely phenotyping these women with genetics, and I'm a little uncertain about regarding the clinical applications and the costs for our patients, and what is the balance between costs and advantages for our patients. Everything is interesting, and research is also for exploring, but what about the clinical application? Because your data are telling us that women affected by PMOS has a higher metabolic risk or metabolic alterations beyond age and BMI, but it is an old, we already know it. What's the advantage?
I love philosophical questions, and thanks for having me back. I think that's an excellent point, and I think there is a lot to be determined with the genomic analysis and how this will actually be used in clinical practice. And I think a lot will depend on what they will show, because I think if, especially using genomics, you better personalize the risk that each patient has for cardiometabolic diseases, that can help personalize the monitoring that these patients will have, the cost that will be put on them. So maybe eventually this will be a good thing to have more information about what you need to do next and what is your personalized risk to develop some things. I think this is where we are going.
Okay, thank you for your answers. You can go now. So let's move to the next presentation. I think we always focus on the ovary, and we also focus on metabolism, but I find very intriguing to focus on the uterus. So please, Young-Si, Dr. Young-Si, you are very welcome. She will talk about impaired uterine developmental programming in PCOS, impact of reduced dimensions and morphological anomalies on ART pregnancy loss. Thank you.
Thanks, ESHRE, for giving me this opportunity, and thanks to the chairman for your very kind introduction. My name is Yun Xie. I come from China. I'm very honored to have this opportunity to present some of our research findings. The title of my presentation is Impaired Uterine Developmental Programming in PCOS, Impact of Reduced Dimensions and Morphological Abnormalities on ART Pregnancy Loss. This project was supervised by Professor Xiaoyan Liang, and the other co-author is Dr. Yun Hu. The authors declare that there are no conflicts of interest, and we do not have any possible conflicts of interest. PCOS, which we now refer to as PCOS, affect around 170 million women of reproductive age worldwide. After ruling out other possible disorders, PCOS is diagnosed in adults when at least two of the following criteria are met: oligo anevolution, clinical or biochemical signs of hyperandrogenism, and polycystic ovaries on ultrasound or elevated AMH levels. Overall, PCOS is more than an ovarian disorder. It has wide-ranging effects across multiple body systems. It can affect metabolism, skin, and mental health. Then, let's briefly review how the normal uterus develops. During fetal life, the uterus develops from the uterogenital ridge under the influence of the androgens and AMH. Until puberty, under the increase of estrogens and progesterone, the uterine volume gradually increased. The myometron becomes thicker, and the endometrium gains the ability to undergo cyclical changes. However, many mothers of the patients with PCOS also have PCOS themselves, so the fetus may be exposed to elevated androgen level during pregnancy, which could influence uterine development during the fetal life. Later, during the puberty, the uterus may be exposed to a high androgen level, continuous estrogen, and insufficient progesterone exposure, may further affect the normal uterine development. Therefore, we raise the question, is PCOS associated with altered uterine size and morphology on 3D ultrasound? And does this change affect ART pregnancies and live birth outcomes? So we conduct a retrospective study. The part one of our study, we include PCOS women and non-PCOS controls who will conduct three-dimensional ultrasound at our center. We compare the uterine dimensions, uterine volume, and uterine morphology between them. In the part one results, we found that PCOS patients had significantly small uterine length, anteroposterior diameter, and transverse diameter compared to the control group. It results in a reduced overall uterine volume. We then compare the uterine morphology between two groups. The PMOS group shows a higher rate of uterine morphological abnormalities, reaching 14.5%, compared with 9.7% in the control group. When we further examined the specific type of abnormalities, we found that the differences was mainly driven by a higher prevalence of arcuate uterus in the PMOS group. The Part 2 study included ART circles with good quality embryo transferred treated at our center. After 1-to-1 propensity score matching, 2,414 circles with PMOS and 2,414 control circles were included in the final analysis. The matching variables include age, infertility duration, infertility type, transfer circle type, and embryo culture date. So we evaluate several reproductive outcomes, including biochemical pregnancy, clinical pregnancy, miscarriage, and live birth. The baseline including age, duration of infertility, type of transfer circle, and embryo development days between these two groups has no differences. It ensured the comparability of the results. We compared the clinical outcome of two groups after transferring high-quality embryos. First, the biochemical pregnancy rate was significantly higher in PMOS group than in the control group, 66.9% in PMOS group compared with the 69% in the control group. This may suggest that the endometrium in women with PMOS is more responsive to high hormonal stimulation. Second, the overall miscarriage rate was also higher in the PMOS group. This finding raises the possibility that altered uterine development may contribute to an increased risk of pregnancy loss in women with PMOS. However, there are no significant differences between the two groups in clinical pregnancy rate and live birth rate. So these results suggest that although PMOS may be associated with changes in uterine development and early pregnancy loss, appropriate treatment may help them maintain a comparable final reproductive outcomes. However, our study also has several limitations. This is a retrospective single-center study, so residual confounding cannot be completely avoided. Second, detailed hormonal and metabolic phenotyping was not available for all the participations. Finally, we did not have the longitudinal follow-up data, which limits our ability to evaluate long-term changes in uterine development and reproductive outcomes. Our finding redefines PMOS as a system condition affecting uterine developmental programming. The increased miscarriage risk underscores the need for preconception 3D ultrasound phenotyping. Early intervention focusing on hormonal optimization during the formative reproductive years may be crucial to improve uterine receptivity and long-term opportunity safely. Finally, I would like to express my gratitude to my supervisor, Dr. Xiaoyan Liang, and the co-author, Dr. Yun Hu, for their very kind gradients and the support from the department and the foundation. Thanks for your attention.
Thank you for presenting your data. Is there any question from the audience?
Excuse me, I have some question.
Where are you? Okay,
The
go
first
ahead.
one, your study is so interesting for me, thank you. But I want to ask you whether you can state the age of puberty of the control and disease group. Is it the first one? And also, do you consider the karyotype of your patient when you include in your study? And also, do you use kappa measurement to denote that every single of your measurement about the diameter of the uterus is okay? I mean that you measure it how many times and how many people measure this, or you just measure by yourself one time, for example. And also the
Excuse me, we have to allow other people to make questions, so just one or two maximum.
Okay.
That's enough. Thank you.
I beg pardon your question.
The first one, that whether you noted about the puberty of your controls and disease group, because I think the age of puberty may affect the diameter of the uterus of the patient and the control.
Okay, thank you for your questions. I'm sorry I didn't show the data. We have compared these two groups, the age but the two groups' age have no significant differences in the ultrasound data.
No, the age of the puberty of the patient.
Age at puberty, when the puberty occurred in that patient. Did you analyze the first period, the menarche and pubarche, in your patients?
Oh, yes, they are in the same stage.
Okay, and other questions is about the infertility cause of your control. So in the disease group, the patients suffer from PCOS, infertility. However, in the control group, which is the main factor that's called infertility in the control?
Our control groups just not PCOS patients, and we delete the
Okay, you excluded the male factors. You excluded the male factor of infertility, or not? Men were okay.
We just compare the PCOS groups and the no PCOS groups.
Okay, okay.
So it's unclear.
Thank you very much. Let's move to Professor Balen and then Professor Piltonen.
Hello again, Adam Balen from the UK. Thank you for beginning to explore, which is obviously a very interesting topic, and I appreciate you opening this dialogue. May I suggest that in the first part of your study, when you're looking at uterine dimensions, you then exclude those who have the uterine anomalies and do a comparison between those with a normal-looking uterus in the PCOS compared with the controls. Did you do that? Because if you have an arcuate or a different shaped uterus, that will affect the dimensions. It's worth looking at. I think it's a very interesting topic, so thank you for beginning to explore it. I think there's a lot more to look into here.
Thank you for your advice.
Professor Piltonen?
Thank you. I completely agree with Professor Balen. So I was also thinking about the control groups. I think thinking about the first control group, is that selected, or is that is that infertility population or non-infertility population, the controls that you have in your first part of your study?
All the patients include this analysis is all people who could not get pregnancy natural. So it's
Okay.
Both of them also the infertility women.
Okay, was it so that you had only very few controls in your first analysis? Why didn't you include then larger number of women in the 3D analysis? Would you be able to do that?
Oh, that's a very good question. It is our limitation. We just do a retrospective study. So we found that in our data, there was less control patients we do this examination because not all the patients come to our center. We will conduct this examination for them. So the control group was very...
So they were only available. Okay, that's fine.
I'm very sorry, we don't have time for further questions. Maybe you can discuss with the speaker after the session. Please, Professor Hamburg.
Thank you.
The next presentation is by Dr. Ahmad Soliman from Mansoura in Egypt, entitled Extended Letrozole Protocol versus Letrozole-Inositol Combination for Ovulation Induction in Letrozole-Resistant Polycystic Ovary Syndrome Women. Is Dr. Soliman here? Oh. Well, that's probably saved him a lot of bother.
We have Professor Ben Moll who wants
So,
to say something, please.
well, maybe a comment to ESHRE. My name is Ben Moll from Melbourne, Australia. First of all, everyone in Egypt, congratulations on kicking us out of the tournament. And, good luck at the next match. But more serious, I had concerns about this abstract because it was not registered. And I think that in itself should be a reason for ESHRE not to accept these abstracts. I have explicitly communicated that already years ago, and still it was ignored. I have approached Dr. Soliman up front with questions about his presentation. I have that here in WhatsApp, and maybe that's the reason he is not here. I don't know. But I would like to call specifically the two chairs to take it back to ESHRE to get a better check of the trustworthiness of the research that it presented at the meeting. There were very good abstracts, RCTs, only a poster or even rejected that could have been presented here.
Thank you. I have it on very good authority that as from next year, no abstract regarding an RCT will be accepted without a registration number. So I think this is a step in the right direction. The other two things I wanted to bring up from this abstract, unfortunately I can't get an answer for it, is that I think it's well recognized that the letrozole resistance in the PCOS population is about 5%. So I wanted to ask Dr. Soliman, how long did it take for him to recruit 200 letrozole-resistant patients? That must have taken an awful long time. Secondly, from the abstract, it appears that nearly all those that ovulated actually conceived, which again is a remarkable record. I don't know whether anybody has got any other comments on these 2 points, or anybody else's experience with letrozole. Is it similar?
Yeah, thanks, Roy. Rick LeGros again from Penn State. I'm just going to bookend on to Ben Moll that a trial must be registered prior to randomization of the first subject. You can't register a trial when you're halfway through the trial. So it's very important that you register a trial prior to randomizing the first patient.
Thanks, Rick. Anyone else got a comment? We still have a few minutes.
Well, if it stays silent and there's still the time, let's make it clear these data are fake, right? So my request also to ESHRE is to remove this material from the written abstract book, because it will come in meta-analysis in the future if you don't do that.
Cindy Farquhar from New Zealand. I just wanted to support the two people who stood up and about this particular abstract that was accepted, and also your comments, Roy. I agree entirely with it, and I think if ESHRE can make sure this happens, while we've got the time, we've also got the issue of RCTs presented as abstracts at ESHRE that have never been published in a full publication. It might surprise you to find out that it's about 50% of the RCTs presented never make it into a medical journal. So another problem. And many of those were unregistered trials. Thank you.
Thank you, Cindy. And obviously what we've learned from this episode, there are plenty of things to learn, and I'm sure that ESHRE will take this to heart, and certainly for next year's abstract there will be a difference. Anyone else got any comments?
I can make a comment. I am among all the reviewers that ESHRE invites. There is a rigorous process for reviewing the abstract which are submitted to ESHRE every year. It's a very high number, and as a reviewer I feel the responsibility to spend my time in reviewing each abstract, because I know I have the responsibility for selecting young doctors which will have the opportunity to come here and present their data and their work. And also I feel the responsibility to check every aspect of the abstracts. Of course, I don't have the expertise in biostatistics as Professor Ben Moll, but I try to understand if the results are fabricated or not, because it's a worldwide problem. I think we have the opportunity to say it. And as far as PMOS or PCOS regards, I think that while the terminology may change, our goal has to remain the same: to improve evidence, to produce good evidence, even if it's very hard. We have to find funds and time and people working with us, but our goal must remain the same. Thank you.
One other point, maybe in regard to this, is anybody who's tried to organise an RCT, especially in the UK, finds it extremely difficult. There is an absolute mass of bureaucracy to overcome. Now, I'm not talking about just the registration, the pre-registration of an RCT, which is obviously essential, but everything that goes on around it. And I myself have given up 2 RCTs because of the bureaucracy involved, which certainly could be cut down. So please, let's make it easier to register without disregarding the principles that we've heard about today.
may add that often industries doesn't found some RCT, because if you organize an RCT, if you plan an RCT, you need an insurance for your patients, regardless of the drugs, and sometimes we prescribe very cheap drugs and we are not supported. It's difficult to find the funding for also over the bureaucracy. We have to find the funds. So I think we have 5 minutes left until the next presentation. 5, yeah, 5. We have a question from a virtual participant. I think it refers to the previous talk. I don't know if Dr. Yu is still here. Poor hair.
Daniela.
Oh, please, Professor Levin, it's a pleasure to listen to your point of view.
Yeah, I would advise you to look at the latest PCOS newsletter, in which I reviewed the number of publications on PCOS during, let's say, the last 30 years or so, and the number of retractions. And there were 99 retractions, and the majority of these retractions were on supposed effects of things like inositol, on pregnancy rates, on ovulation induction outcome. The majority of these papers came from Egypt, that was number 1, China number 2, Iran number 3. So really, that proves that a lot of the stuff which we shouldn't look at comes from these three countries. Yeah. And the rest were only limited numbers, like 3 or 4 from Italy, 1 or 2 from the US, a few European countries. So it really, out of 31,000 papers, 96 retractions. It's not that much, but we should be aware that the problem is probably bigger than that.
Yeah, thanks very much, Jo. One other question before you go. How much do you think that these studies have been influenced by the industry?
I really don't know, because I didn't look into that, and whether they were industry funded or not. I don't think that's a major issue. The issue is most of the time what you were saying already, that inclusions were so high that it was unbelievable that I did that in that limited number of time. And we see that all the time. I'm a member of an integrity committee looking for one journal into this, and it's really always about these things. Inclusions which were done in a rate which is really unrealistic, and as you were saying, we see the same all over Europe, that we think that we can include 200 patients, and it takes much longer than anticipated. And all these studies, they show inclusion rates which are really unrealistic.
Professor Levin, I respect your opinion, but we are in an international contest. So I don't think it's fair to say that we should, I don't think we have to talk on a national basis. We have to select works from China, from Iran, from Egypt. I'm not sure we can say something like that. I think that it's a worldwide international responsibility, and also the selection of referees, it's a responsibility for the journals and the editors-in-chief. It's a very time-consuming activity, but it's a very time-consuming job, but we have to we have not to select a paper based on the country where it is published. Okay. What's the next? So I think that talking about inositol and talking about evidence, it's now time, it's 11, more or less, to move to the next presenter. Dr. Joyce Sung. She will talk about inositol supplementation in polycystic ovary syndrome. She will present a systematic review of evidence. Thank you very much.
Thank you. Dear Chairman, dear members of the Society, dear guests, my name is Joy Sung and I'm a final year medical student from Monash University in Melbourne, Australia. Thank you for the very interesting conversation which sets up my presentation well. I will be presenting on inositol for the supplement of PCOS with a focus on data integrity. I would like to first acknowledge the recent name change of this condition to PMOS, but for the sake of this presentation, I will be referring to it by its previous name. These are our conflicts of interest. Let's start with what is inositol. Inositol was first discovered in the 1850s by Johann Joseph Scherer. It is a naturally occurring sugar that is produced within the body, and it's thought to have some insulin sensitizing effects. Because of this, in recent years, it's been widely adopted as a natural alternative therapy for conditions like PCOS, gestational diabetes, and obesity. It is also easily accessible. It can be obtained over the counter or purchased online. This is a systematic review done by FITS in 2023, which directly informed the International PCOS guidelines. These guidelines made two important statements on inositol. Firstly, for metabolic measures, it could be considered based on individual preferences, and for fertility outcomes, it's classified as experimental therapy. This may not come as a surprise since there have been many meta-analyses with positive conclusions. For example, for achieving a regular menstrual cycle, this study from GREF concludes with a risk ratio of 1.79 when comparing inositol to a placebo, as well as FITS that concludes inositol is comparable to metformin. However, recently there is a growing concern regarding trustworthiness in the literature. FITS was the first to formally assess trustworthiness in these studies and excluded 13 out of 43 studies following integrity screening. Since then, new methods have been developed to assess trustworthiness. Therefore, our aim is to re-evaluate the trustworthiness of RCTs in a holistic way, by also taking into account statistical reproducibility and randomization plausibility. We included any new studies that have been published in the meantime, and our ultimate goal is to support decision-making for women with PCOS. Here are our methods. We used the same group of RCTs as FITS et al. And updated the search to December of 2025. Our trustworthiness assessment consists of 4 main components. The first is our TRACT assessment. TRACT is a screening checklist used to assess trustworthiness in randomized controlled trials and consists of these 7 domains. Each study is assessed by 2 authors independently, and any conflicting results are resolved by a 3rd reviewer. Each study is classified as low, moderate, or high risk for integrity concerns. We attempted to reproduce p-values from summary statistics by applying the independent samples t-test and chi-square test. We then assessed the variability of baseline characteristics by applying the Monte Carlo simulations and by tallying any extreme baseline p-values on either end of the spectrum. We made note of any remarkable findings that we observed during our assessment, and throughout various stages of our assessment, we approached all corresponding authors to seek clarification on our findings, as well as give an opportunity for them to correct our assessment. With all of this in mind, we classified each study as meeting or not meeting our trustworthiness criteria. In summary, here are the 5 items a study would need to satisfy to be considered meeting our trustworthiness criteria. If a study was retracted or carries an expression of concern, it is automatically classified as not meeting our trustworthiness criteria. And in our review, we have 9 of these studies, 6 from Italy, 2 from Iran, and 1 from Georgia. We started with 43 studies, added 6 from our search. We excluded 2 studies for not having full text, as well as the 9 studies that was previously mentioned. So we ended up with 38 studies in our integrity assessment. Moving on to the results, Following our tracked assessment, we have 14 high-risk studies, 8 moderate risk, 16 low-risk studies. The most frequently flagged domain is governance, which requires prospective trial registration and ethics approval. Item 2 is the reproducibility of p-values, and there is a wide variability in the results in this item between 0 to 100%. There were 8 studies with reassuring findings, and on the other hand, 6 studies with a high proportion of p-values that we could not reproduce. We were unable to assess 12 studies in this item due to various reasons, the most common being statistical methods that were not reproducible using summary statistics. Next, I would like to show you the Monte Carlo simulation of baseline p-values. But first, how do baseline p-values reflect randomization? In a properly randomized cohort, you wouldn't expect 2 groups to be systematically different or extremely similar in a way where the p-value falls below 0.05 or above 0.95. And a frequent occurrence of these values would reflect inadequate randomization. This graph on the right represents the categorical baseline p-values, and the red line is a uniform distribution between 0 and 1. We can see that the categorical baseline p-values follows the trend line well, but for continuous variables, there is a clear deviation from the trend line and accumulation of values around 1. To look into this further, we tallied all extreme baseline p-values in each study, and we found that 6 studies have more than 40% of baseline p-values that are statistically significant. This questions adequate randomization. Lastly, I will show you examples of some remarkable findings that we observed during our assessment. On the left here is Frusetti 2017, and when we compare it to a study done in 2009 by the same first author, we can see a clear overlap of baseline values. It's important to note that these 2 studies have no overlap in recruitment periods. Here is a similar pattern observed in PISO 2014 that has the same author group as Lagana 2015. These outcome tables have remarkably similar standard deviations that differ by a single digit. However, we know that this is not an identical group that is being reused between 2 studies, because the similarities are not consistent across all variables. The means are also different, as well as the group sizes. This next example is from Shock Report 2019, where we found 6 out of 7 of these authors have had previous retractions or expressions of concern. Notably, 1 author has 35 retractions and 19 expressions of concern. Our last example is from Kirania 2017. These are 3 outcome tables between 3 groups, and we found that 9 out of 18 measures have a 0% change in mean and standard deviation after treatment. This is in a cohort of 76 participants and a duration of 4 months. With all of these findings in mind, we were able to classify each study into meeting or not meeting our trustworthiness criteria. And any studies where we could not apply all assessments, our classification is based on the absence or presence of remarkable findings. Here are the 32 studies that did not meet our trustworthiness criteria for various reasons. 8 studies were unable to satisfy any of our 4 requirements, while 3 studies were 1 item away from meeting our criteria. Here's a reminder of the 9 studies that were automatically classified at the beginning of our assessment, which brings us to 41 studies not meeting our trustworthiness criteria. We are left with 6 studies that do meet our trustworthiness criteria, with 4 of them concluding that inositol has beneficial effects and 1 study concluding that it is comparable to metformin. The remaining 2 studies, Raven and Vanderwell, conclude with evidence of no benefit on metabolic outcomes and pregnancy complications, respectively. Vanderwell 2025 is also the largest study in our review, with 464 participants, and is the only study with clinical endpoints. The remaining 5 studies report on biochemical markers only. Following our review, we've come to 2 main conclusions. First, a large majority of studies evaluating inositol does not meet our trustworthiness criteria. Secondly, among the studies that do meet our criteria, we could not draw reliable conclusions on the benefit of inositol on PCOS due to the small number of studies and their heterogeneous outcomes. I would like to acknowledge the rest of my team, and thank you very much for your attention.
I swear it wasn't organized, the absence of the previous speaker, and now. Is there any question from the audience? Question or comments? Professor Ligro, thank you.
Thank you so much for that presentation. I'm wondering if you went back to the last millennium and looked at the John Nestler paper of D-chiroinositol that was published in New England Journal in 1997. So was there a time limit of studies you included in this?
So our study inclusion was based on the FITS review. So we included all the studies that they looked at, as well as updating the search between the end of their recruitment to December of 2025. So we did include the Nestler study from 2009 at the top here.
Okay, yeah, there was an earlier one from 1997. And just out of history, since most people weren't born then that are probably here, is that a company subsequently did 2 phase 2 studies that were negative, and the company never published the results. So it's a publication bias favoring the initial small RCT, not supported by 2 independent RCTs performed later. So I think this bias goes back almost to the beginning of inositol.
Thank you for that.
Is there any further question? How many of you prescribe inositol to their PMS women? Raise your hands. Over there, over there. Yeah. Okay, there is, I think, 5% of people prescribing inositol to their patients. And what about metformin? How many of you prescribe metformin? Raise your hands, don't be shy. The majority, it seems to me.
I have a question, please.
Please, go ahead.
My name is Fatima Hussein. I'm from the UK. I'm a gynecologist. Thank you so much for your presentation, and thank you to all the speakers so far. With regard to inositol, it's actually, I don't think it's not doctor-driven. Women go get it because we don't have to prescribe it. So I think the focus about non-prescribed medications for PCOS, PMOS, that is a very important area for us to look at because they think this is going to be a better natural treatment. So do you know of any studies that have looked at the uptake of inositol by women without being recommended by physicians?
I don't have the answer to your question. However, I do agree to your point, being the fact that inositol is so easily accessible and they can bypass a doctor's prescription. We believe that it delays any effective treatment as well as diagnosis of PCOS or PMOS. So I completely agree with you.
Thank you very much.
Dr. Sung, may I make a question maybe? There are so many forms of inositol, dichiroinositol, myoinositol. They are in over-the-counter drugs preparations. They are combined with folic acids. It seems to me always with folic acids and combined with other micronutrients and vitamins and so on. What's your opinion regarding the heterogeneity of preparations and doses also administered to the participants in these studies you presented?
Yeah, so there were a few studies that looked at different ratios of inositol and different dosages. Our ultimate conclusion is that there is no evidence to support any form of inositol for PCOS. Whether one dosage is superior over the other, I do not have the answer for that.
Thank you. We have time for a quick question and answer from Professor Piltonen.
Thank you. Terhi Piltonen from Finland. Just a comment, when we were doing the guideline, the PCOS guideline in 2023, and there are patient representatives in this group, and I was the chair of the GDG4, where Daniela, you were also sitting. So at that time, when we were looking at the evidence of inositol, and there were the patient representatives there, I think they were very shocked, and they were also very sad about the marketing that had gone over inositol, the usage and the push to use it during the infertility treatments, not by the doctors, but you know, by the medical, the pharmaceutical companies or whoever who provided. So I think they were quite shocked how weak the actual evidence was behind inositol, and that was where we also tried to translate that into the guideline recommendations. So I think we need to be really careful considering all that you have now presented. So I'm just hoping that us as physicians, that we can also translate this to our patients, that you need to consider whether they are putting their money in the right, you know, pocket, so to say. Is this feasible for them? Because it's not cheap. Thank you.
Thank you for raising that point. I think, yeah, it's definitely very important to consider the context of the situation. Inositol is not cheap, and there's also strong commercial interest at the moment for this product. As mentioned before, it can be obtained very easily by patients without a doctor's advice. So that also comes hand in hand with our review today.
Thank you very much. Thank you. After this session, I'm beginning to worry that we can't trust anyone. But certainly, you can trust this last study. I have it on very good authority. It's presented by Dr. Pedro Mello. The study initiated in Birmingham in the UK. It's letrozole versus clomiphene with or without metformin for ovulation induction in women with polycystic ovary syndrome. And it's a multi-center 2x2 factorial design RCT. Dr. Mello.
Good morning. Thank you very much for that introduction. It is a mouthful, isn't it? Thank you very much for the opportunity to present the results of the LOCI trial for the first time internationally today. And trigger warning, it is an RCT, and it is in fact the largest RCT ever conducted on the question of ovulation induction in PCOS. I don't have any conflicts of interest to declare in relation to any of these drugs. A quick word on naming. We know that a couple of months ago, a global consensus changed the name of PCOS to PMOS. I will ask you to forgive me because I will use the two terms interchangeably during this talk, mostly because my brain can't get around change a lot of the time. But irrespective of how you call it, the reality is that this is the most common endocrine disorder in women of reproductive age. And we know that crucially, it accounts for most cases of anovulation. And we know that for anovulation, a simple drug is often all that is needed to restore ovulation in these individuals. And options include clomiphene citrate, which has been historically used since the 1960s, and clomid acts centrally by inhibiting estradiol receptors, in turn increasing FSH secretion by the anterior pituitary. Since the early 2000s, we've also used letrozole, which is an aromatase inhibitor acting peripherally, also decreasing the circulating levels of estrogen and in turn increasing FSH secretion centrally. And people also use metformin, which is an insulin sensitizer, which addresses one of the most crucial pathophysiological mechanisms underpinning anovulation in PCOS. So here's the gap. The most influential trial published on this question was conducted by Rick LeGros in the room and published in the New England Journal in 2014. And at the time of this trial, which is absolutely paramount, what it did was compare letrozole with clomiphene. And this trial favored immensely letrozole, so a 44% higher live birth rate in people receiving that in comparison to clomiphene. It was also a trial conducted specifically in a US population where a third of participants had a BMI over 39, the other third had a BMI between 30 and 39, and a minority had a BMI lower than 30. The other aspect of this is that the trial didn't look at metformin. So at the time, the National Institute for Health Research in the UK felt that there was still a need for a trial to be conducted in a UK setting, and crucially looking at whether metformin accrued any value to these interventions. So LOCI was designed to answer three questions, really. Number one, is letrozole superior to clomiphene in the UK population? Secondly, is metformin superior to placebo? And thirdly, does adding metformin to letrozole accrue any benefits to clomiphene plus metformin? To answer that question, we conducted the LOCI, which was a 2x2 factorial trial. What that means is that people were randomized to receiving either letrozole or clomiphene, and at the same time, independently, they were also randomized to receiving metformin or placebo. We recruited women who fulfilled the Rotterdam criteria, and crucially, at ovulation. All of them were younger than 43, and we capped the BMI at 35, which is in line with NHS practice in the UK. Women were given letrozole or clomiphene in usual dosages, so up titrated to 3 tablets a day for 7.5 milligrams with letrozole or 150 clomiphene. And in addition to that, they were given either metformin up titrated to about 1,500 milligrams a day, or 3 tablets of equivalent placebo. Ovulation induction was conducted up to 6 cycles or 240 days, and metformin or placebo were continued at the latest until 14 completed weeks of gestation if people fell pregnant. And we looked at live birth rates at or beyond 34 weeks as our primary outcome, and this was really applied by the trial. Over the course of 3.5 years, we assessed over 4,000 participants or prospective participants for their eligibility, of whom we included 1,739 women across 48 centres in England, Scotland and Wales. Most of our participants were younger than 35, and most of them had a BMI less than 30. Now for the headline results. Overall, our live birth rate was 30.9% for the whole cohort. When we compared letrozole with clomiphene, we did not find a difference in live birth rates between the two interventions, with a rate of 35.3 for letrozole and 32.8 for clomiphene. When we compared metformin versus placebo, we also did not find a difference between the two groups, with metformin achieving a live birth rate of 35.0% and placebo at 33.1%. And for the combination question, we also didn't find a difference. So metformin didn't appear to accrue any benefit to letrozole compared to clomiphene. We then examined a plethora of secondary outcomes, with which I present to you the ones that are perhaps more pertinent to this talk. So the ovulation rate was marginally superior with letrozole by about 5 percentage points. The miscarriage rates did not differ between the two groups. There was a miscarriage rate hovering between 10 and 11%. And on the subject of multiple pregnancy, the multiple pregnancy rates did not differ between the two groups either. We had pre-specified a number of subgroup analyses. They include several parameters which were all specified a priori. I won't go into all of them because a lot of these are merely hypothesis generating, and in addition to that, this is a landscape of negative results really. But if you zoom in, what you can see is that our key pre-specified subgroup of special interest was according to BMI, particularly knowing what happened with Rick Legros trial in 2014. And what's clear here is that if you focus on a population of people with a BMI of 30 or above, there was a 24% improvement in live birth rate with letrozole compared with clomiphene. In terms of safety, there were no differences, no material differences between the different groups in terms of serious adverse events, OHSS, or congenital anomalies. So how do you square this with what's been published before? And I've tried to compare and contrast Legros' trial with ours. And I think the first thing to say is when people ask, well, did we get to different answers in the end? I think perhaps the question is more, did we look at different populations? And I think these two trials, in some ways, sit at polar opposites of a spectrum where Rick Legros might have looked at people whose BMI was perhaps a bit on the higher end of the spectrum, whereas we looked at people whose BMI was capped at 35, which again is perhaps questionable from an ethical standpoint, and yet, nevertheless, it is what we do in the UK. Our cap was 35, and 35 kilogram per square meter was indeed the mean BMI in the Legros trial. Our average BMI was 28. In addition to that, we looked at the metformin question, and interestingly, our control live birth rate was actually quite significantly higher than that of the clomiphene group in Legros' trial. Importantly, we did not find the effect size that Legros did in their trial, which is something that merits additional considerations. And mechanistically, it is plausible that letrozole would exert its effect and still thrive to some extent in people with high adiposity. And the reason for that is because letrozole acts peripherally upon fat cells, inhibiting aromatase, whereas clomiphene acts centrally. And two caveats here. Well, the latter stems from the former, really, which is the fact that clomiphene is highly lipophilic, which means that it does tend to have a predisposition to remain trapped in fat tissue. And if it does so, then it can't reach its target, it can't reach the pituitary. So it's not so much that as adiposity increases, the effect of letrozole improves, it's more the fact that as the BMI rises, the effectiveness of clomiphene rapidly diminishes. That's what we think. The future involves, well, a question of phenotypes, really, and trying to pull together data from all of these trials to ascertain whether people with different characteristics would respond differently to these drugs. I'd like to end by thanking all participants in the trial, and perhaps to circle back to what we were saying earlier in terms of research integrity. I think people are right. It's not easy to conduct large RCTs in the UK, and yet it's not impossible. And I think LOSI is an example of that. This was a trial that was conducted in the very depths of the pandemic, so 2020 to 2024. And yet, we managed to conduct the largest trial ever in this field, superior to the sum of all individual trials that had been conducted up until now. And I think that's just testament to the ferocious determination of NHS workers and research nurses across the country. So thank you to everyone who's recruited for this trial, all the way to from the bottom to the top. Thank you very much. I'll take questions.
Professor Legros, I'm sure you have a comment.
No, I mean, first of all, I want to congratulate you on a great trial, and I can't agree with you more on your interpretation of it. It really involves different populations, and an obese population, such as we have in the U.S., is more likely to benefit from letrozole. I have to say I'm more disappointed because I would have hoped that metformin would have had some additive benefit. But I want to pull out one thing that you showed in that data, and you know, metformin has been proposed to prevent miscarriage in women with PCOS, and I found it tantalizing that the women with 1 to 2 miscarriages had a benefit with metformin. So is that something, you know, given the interest of your group in miscarriage, is that something worth pursuing, do you think?
Absolutely, and that's something that, well, I didn't have time to show in this presentation, but it's true. So for people who had 1 or 2 miscarriages previously, there was a 57% increase in live birth rates. So that is a powerful signal. It's nevertheless still hypothesis generating, but I think that's something that will probably come out of the IPD that we're planning to do. But absolutely, I agree that there is a powerful signal there, and it's the strongest signal we've seen for the data.
And you're welcome to our data, so we look forward
Thank you.
to IBD.
Thank you for saying that publicly. Thank you.
Can I ask the question?
Yeah.
Niels Lombok from the back of the room.
Yeah, go on now, Niels.
Okay. Well, I just want to congratulate you with your wonderful work, but want to underscore here, based on your presentation, the importance of replication, also of good work. I mean, we as clinicians often rely on single, well-conducted, randomized controlled trials and then start changing our practice. Whereas, for example, in other disciplines like chemic or physics, they do not rely on just one experiment, but they want to have more. So I'm in favor of replicating well-conducted studies also. And well, I think your study is just a proof of the value of that approach. Thank you very much.
Thank you for saying that. Thank you.
Thank you, Neil. One last question from the lady here, please.
Hi, Grace Dugdale from Leeds in the UK. Sorry, I may have missed on the slides, but I just wanted to ask the patients with insulin resistance, did they not show any benefit with metformin either?
No, they didn't actually.
Super interesting.
It is, yeah.
Okay,
Thank
thanks,
you.
Grace. Well, right on time. We're going to conclude this session. I'd like to thank my co-chair, Daniela Romualdi, and a wonderful audience, and I think this has been an excellent session. Thank you all.